Okay, let's look at our first case, and we'll try to use the pole EV, so if you have that fired up, that will be helpful. Here's a 72-year-old with a history of syncope, and here's an abbreviated carotid duplex, and I'm showing you a little bit of the ICA here, which has pretty much a homogeneous color pattern, and I'm showing you a sample from the distal common carotid. That's the first waveform, and it's got a velocity of 37 centimeters per second. So as we go over the case, I want you to look at all the factors that we talked about earlier. Look for presence of plaque, look at the flow pattern, look at the velocities and the waveform shape. And there's a couple of things that should just strike you immediately and as a clue. First of all, we have this big shadow here in the area of the bifurcation, right in the proximal ICA. So it looks like a big calcified plaque there. The other thing I want you to notice about this case is although the waveform looks pretty good, the velocity is way low. Now, of course, you want to look at the contralateral side to see if it's also low, but 37 centimeters per second is way below that 60 to 100 centimeters per second that you think about as a normal range. Now, here's the rest of the case that I wanted to show. We're looking now at the ICA on the other side of the calcified plaque, and we have a velocity of 124 centimeters per second, and you can see the waveform. Now, we've talked about this type of waveform earlier, right? There's a couple of features about it that are interesting. So you look at the fact that it's not as well defined as a normal waveform, has a shaggy appearance. And also, if you look at the upstroke, it's rather delayed. It doesn't have that rapid systolic upstroke. It's sort of taking its time to get to peak systole. So the question is, you're going to call this a stenosis when it's 124 centimeters per second, right? I mean, our cutoff is 125. So does that make it less than 50%? Does it put it in the 50 to 69% category because it's right on the borderline? Or would you call it more? Would you say maybe it's greater than 70%? Now, not likely occluded because we do see some distal flow. So which of these would you say in your report? A few people weighing in, and we have a few that say it's greater than 70%, and I'm very happy to see that. Only because of the fact that when you look at that waveform, it is distinctly abnormal and had all the post-stenotic features of a significant stenosis. Now, I do think that it's kind of hard to say it's greater than 70% when you don't actually see the lesion, right? As we analyze the case, we could see that the waveform from the common carotid artery had a nice normal upstroke, right? Normal looking waveform, but the velocity was too low. So that was the first clue that there was some outflow obstruction. When we look at the ICA, as we already sort of mentioned, it has an abnormal appearance. It's a shaggy waveform with a delayed upstroke, a TARDIS appearance, suggesting that there is something going on behind that plaque that's probably significant. Now, we have a couple of approaches to this. You can go back in the room, either yourself or you can send your sonographer if you see the case before the patient's gone and say, you know what, take a closer look. And the way you can do that is sort of by scanning around the plaque, right? You can go from anterior all the way to posterior, seeing if you can see into the vessel. And by doing so here, we actually get a window where the velocity is over 300 centimeters per second. I don't even think we're in the tightest part of the lesion here because it's still a shaggy looking waveform with a bidirectional signal indicating we're probably a little post-stenotic, but at least now you know you've confirmed it's a high-grade stenosis, and it went on to MR to show that exactly where the lesion is behind the calcified plaque. So again, take-home points from a case like this is, if you have a large calcified plaque, it's possible you could be missing something significant. Check around the plaque, additional acoustic windows. Sample carefully above and below the plaque, so when you see a post-stenotic signal there, you can at least infer there's probably something going on that we're just not getting. Maybe we should do a correlative study if we don't get it. Okay, next case. Here's a 68-year-old with dizziness. And this one's a little bit trickier because we're going to look at the right side first. And again, clearly abnormal. But the question is, what's going on? Here I put the velocities on the screen for the common carotid, the proximal ICA, and the vertebral. Couple of abnormalities, which I hope you're thinking, you could say it out loud or just think to yourself, velocities are low, right? It's nowhere near the normal range. The other thing is the waveform shapes. Definitely not what you're used to seeing for a normal carotid, right? If you were to analyze what's wrong with it, you probably would say it's kind of rounded. It doesn't have that nice rapid systolic upstroke. So that's the right side. Now here's the left side. The left side also starts out with a low velocity in the common. But if you look at the waveform, it's very different from the right side, and we'll come back to that. But this has a rapid systolic upstroke, but the velocity is low. Once you get into the ICA, again, we again see a very calcified plaque right here, and an elevated velocity in the ICA that's over 200 centimeters per second. Interestingly, and something we hardly ever talk about, is the vertebral artery. Usually when we talk about the vertebral in the context of a carotid study, it's about direction of flow, right? We never talk so much about the waveforms, we don't talk so much about velocities. But if you get a velocity in a vertebral that's over 200 centimeters per second, you gotta call it abnormal, you gotta say it's stenotic, even though we don't have criteria to grade vertebral artery stenosis. I've never seen it. I don't think it's done. If you know a reference, please let me know. I have not identified it. I'm calling that a stenotic vertebral, and it's likely pretty tight. So far what we have is a stenosis in the ICA that's at least 50 to 69. If you do the ratio, it's really high. And we have a stenosis in the vertebral, but what about that right carotid, right? So here's the question for you. What is going on the right side? We had low velocities and rounded waveforms that we did not see on the left side. So what do you think the diagnosis is? Is it aortic stenosis? Is it aortic insufficiency? Is it a common carotid artery stenosis? Or is it an innominate artery disease? Now, you have all the information you need to make the correct diagnosis here. And this also goes back, and please go ahead and vote. Keep in mind, this relates to the point I made earlier today that you don't need to see the lesion to make the diagnosis and be certain of it. That's what makes this what we do very cool, is that you can, amaze your clinical friends and say, oh, this is clearly D, innominate artery disease. You're absolutely right. Now, how do we know that? Let's go back to the slide. This is a lesion that's affecting not only the carotid artery, but it's also affecting the vertebral and only on the right. So it's not aortic stenosis that would have affected the left side. Certainly not aortic insufficiency, that gives you reversal of flow. It can't be common carotid artery because it's also affecting the vertebral. So it has to be the innominate. There's no other choice. And if you send the patient for a correlative study, we have the contrast MR, you can see the tight stenosis at the origin of the innominate artery. Has to be. You can make that diagnosis. Now, here's another one with funny waveforms. Here's a patient sent, preoperative evaluation for a CABG, and this is just a preoperative workup, and we notice things are funny again. Very low velocity flow in the distal common, and a funny looking waveform. This is an Ant Mini. Anybody know what this is from? If you work in a hospital with a busy cardiac department, you know what this is. Anybody? It's a shy group. All right. It's an intra-aortic balloon pump. And you got to recognize it. If you work in a hospital that uses pumps, this is an intra-aortic balloon pump, and the way you know that is it's got a double peak in systole. The first peak is the balloon that is pushing blood out of the aorta. And then the second bump is going to be the ventricle contracting. So you get the ventricle first, then you get the balloon, and that produces the double bump in the waveform. So that's an intra-aortic balloon pump. Now, the second finding here is that the velocity is elevated, much higher than that. So there's got to be a stenosis. And you can see the plaque, and you can see the aliasing. Here's the contralateral side. On the contralateral side, well, let's see. We have a stenosis in the external, which we don't necessarily grade, we just describe it. And the distal ICA, the velocity goes down. On the left side, the velocities are more in the normal range. So what we're dealing with here is an abnormality that is concerning just the right side. So how are you going to grade this? Distal common is 31, ICA is 233. Is it a 50 to 69? A greater than 70%? Do you think there's something else going on, like it could be a fistula? Or you can't determine it, you need to get a correlative study. All right. So most of you would call it severe, and that could be based on a couple of things. Number one, you just hit the threshold for greater than 70%, right? We use 230 according to the SRU consensus criteria, so it's right at the threshold, fair enough to call it greater than 70%. I think the other thing, though, is that that ratio is extremely high. The ratio is 7.5. So you have such a high ratio, even in the setting of an intra-aortic balloon pump, you have to be concerned that you have a very severe stenosis. But the caveats here, you have marked variability. You can't really rely on the velocity measurements themselves because of the intra-aortic balloon pump, which produces that variability. It's not a true velocity estimate. And because the velocity criteria are not reliable, you can infer that it's a tight stenosis based on the ratio, which you probably should get a correlative study in this case. The other thing that's helpful here is that the distal ICA has sort of a rounded waveform, a TARDIS appearance, which would also go along with a significant stenosis. So let's switch gears for a second. And when we're in the neck, sometimes we see other things that are going on besides carotid disease. He was a 56-year-old male who came for a thyroid sonogram. And he had just had removal of a central line. And this is what we see when examining the neck. And so we see this little swirling pattern right in here. And to orient you, I've put this still image on the side showing this is the internal jugular, and that's the common carotid. All right? And so if we want to sample what type of flow is, notice that we're going to probably place the sample volume right in here where we see the swirling. And this is the pattern that we get. And you can see here sort of a very turbulent pattern. It's a little bit more pulsatile than you expect from just the usual flow pattern in the jugular vein. So you go back into the PACS and you say, well, wait a minute, the patient had a catheter in there. You can see that the patient had a catheter in the neck at that level. So the diagnosis? Fistula? So it's a fistula between what? Well, the carotid's down here. The carotid is separate from the swirling. This is the carotid. This is a pseudoaneurysm from the jugular vein. The carotid's not involved. This is a hole in the jugular, which blood is escaping. It's not so common to see venous pseudoaneurysms, but they can occur. On occasion, we do see venous aneurysms or dilatations, and you can see leaks of the vein. And in this particular case, because it's not an arterial pseudoaneurysm, you could take a more conservative treatment and follow it to see if it closes on its own. If not, then you may consider intervention like a stent. Now, talking about fistulas, here's a 63-year-old female who presented with neck pain after a carotid endarterectomy. And this is more what you were looking for. Here's a patient that presents with a very turbulent pattern that occurs between the carotid artery and the jugular vein. And as Dr. Pozniak had mentioned to you before, there's lots of ways to improve visualization of the fistula, not only for friends, but also for yourself to convince yourself that you can see the communication. So by increasing that scale, you can reduce some of the noise or that brewy artifact that can occur with an AV fistula and find that communication more readily. Another way to prove it to yourself, of course, is to move the sample volume from the artery into the fistula, and you could see here that very high velocity, low resistance shunt pattern from the artery to the vein, because again, there's no resistance to flow into the venous circulation. And then you can drag the sample volume then into the vein and get that arterialized pattern. So fistulas, fairly uncommon. Can't say that I've seen more than a few. And they're typically, the ones that I've seen have been iatrogenic, but they can be related to any kind of trauma. Even less frequently, they can be related to tumors, or they can be congenital. And as similar to fistulas that you see in the groin, you're going to have the same findings. And again, one of the ways that they'll consider treating that if they don't want to intervene surgically is to put in a stent. Another thing you can see is a carotid pseudoaneurysm. Again, those are also usually related to some type of trauma, and that can be iatrogenic. Here we see a large pseudoaneurysm projecting from the carotid artery, and you can see that it is partially thrombosed. And again, similar to what we talked about with groin pseudoaneurysms, you try to see the swirling or yin-yang pattern. When you freeze the image, you'll see this swirling that occurs that Dr. Pozniak calls sort of that scouring effect, because the blood flow is going in, wrapping around, and then coming back out again. And you can sometimes demonstrate that to and fro pattern depending on the size of the neck. Here's a patient who's a 28-year-old IV drug abuser that had a partially thrombosed pseudoaneurysm. Here you can see it here on the side of this image, and here's the neck and the partial filling of the pseudoaneurysm arising from the common carotid artery. And in this particular case, because the neck was very well defined, we were able to demonstrate that to and fro flow pattern. So again, related to trauma, less commonly weakening of the wall that can be due to a connective tissue issue. You can also see pseudoaneurysms related to dissection. It's probably the second most common cause of pseudoaneurysms in the carotid artery. Of course, the concern there is the risk of rupture. Probably least common of all is a true aneurysm of the carotid artery. They occur more commonly in the common carotid than the internal carotid, and they can be related to connective tissue disorders as well as atherosclerosis. Again, not very common, but you have to make sure that you identify the focal enlargement of the artery because there is a risk of rupture. Okay, so here's another patient that presents examination of the neck. History was dizziness. We were doing a carotid study. Here's a look at the bifurcation. And notice that there's somewhat of a mass sitting next to the internal and external carotid arteries. So we focus in on this mass, and we can see it's pretty sizable. It measures 1.6 by 3.4 centimeters, slightly heterogeneous. And if we turn the color onto it, we can see that there is internal vascularity. And the velocity is about 20 centimeters per second. There's no angle correction on it because these are just tiny vessels. There's nothing really to follow. So looking at the mass, what do you think is the most likely diagnosis here? Is it going to be hematoma, a lymph node, a glomus tumor, a sarcoma, or a DVT? Okay. So again, A was hematoma, B was lymph node, C was glomus, D sarcoma, E DVT. Okay, so I think the key to the diagnosis in this case is the location. Think about where lymph nodes occur. Lymph nodes typically don't sit at the bifurcation of the carotid arteries, right? Lymph nodes are typically the cervical in location. They tend to be lower in the neck, less commonly up by the branching of the carotid arteries. So when we see a mass that is at the bifurcation, the diagnosis to consider is the carotid body tumor or the glomus tumor. And in this, here's another example. You can see it sits in the crotch, right at the bifurcation, typically very vascular. So they're located within the adventitia of the carotid bifurcation. They have low malignant potential, but the problem is they locally invade, and they're very stubborn. So they can be treated locally, but they're treated surgically, but they invade locally. So again, the key is they sit in the crotch of the bifurcation. They can encase and surround the carotid vessels. If they go on to continue to grow, they will cause stenosis or occlusion, and they tend to recur if they're not completely removed. All right. This one's a little tougher. And this was a case that we saw was sent to us from the echo lab. Here was a patient that was having an echo, and the cardiologist sent it to the vascular lab because they saw something in the IVC, and they called it a mass. So I'm pointing to the lesion on the left-hand side. And if you look at the video on the right, you can see there's something right over here. Okay? So what do you think the finding is? And again, it's pretty well seen here on the transverse view. Notice its location. It's probably easier to see on the longitudinal view. It's right at the top of the liver, right at the level of the diaphragm, where the IVC is entering into the right atrium, which is why they picked it up on the echo. So now we'll poll and see, what do you think it is? Is it an artifact? Is it a clot? Is it a valve? Or is it some type of foreign body? Okay. So let's see what the responses are. Okay, so majority call it a valve. So if it's a valve, what kind of valve is it? Are there typically valves in the IVC? How often do you see valves in the IVC? Almost never, right? Most of the valves are lower down. Lots of valves in the calf, right, to propel blood up back toward the heart. You get less valves in the thigh at the femoral vessels. And as you move up through the iliacs in the IVC, you practically lose all your valves. But you're right, it is a valve. It's called the Eustachian valve. And Eustachian valve is located right there, right at the end of the IVC as the IVC empties into the right atrium. And you can see the heart right here at the top of the image. And this is a valve that's basically a congenital remnant. It lies at the junction of the IVC and the right atrium. In embryonic life, it directs oxygen-rich blood through the right atrium toward the left atrium in fetal life, and it's variable and can persist into adulthood. So it's interesting, you know, that case that I just showed was the first time I really found one, and now that if you look for it, you can see smaller remnants if you pay attention to that area. So let me show you a bread and butter case, because I wasn't planning on showing much in the way of peripheral arterial, but we do a lot of peripheral artery studies. I mean, this is bread and butter for our lab. And the way we approach peripheral arterial studies is we start out with the indirect exam. We don't duplex everybody. It's very time-consuming, particularly diabetic patients, patients with question claudication. You start doing bilateral lower extremity arterial Dopplers, it's a drain on the lab, particularly when you're very busy. So we start out with the indirect studies. We do ABIs, and frequently we'll add on the segmental pressures, which you see on the diagram next to the cuffs. I know you can't read the numbers, but that's where they are. And we also augment those with the pulse volume recordings, and those are the waveforms on the side. So there's three components to our indirect study: ABI, segmental pressures, PVRs. And between these three tests, you get a lot of information. And our strategy is, if this is a normal test, then there's really little reason to do duplex examination unless the patient truly has claudication, in which case they should be exercised and rescanned. Because patients who have structural and functional obstructive disease will have an abnormal study, as is the case here. So here's a 49-year-old diabetic, smoker, history of MI, it's a great history for atherosclerosis, and 1 block claudication. So how do we analyze this? Very quickly. The ABIs should be close to 1. 1 and above is clearly normal. 0.9 to 1 is borderline. Anything below 0.9 is definitely abnormal. You see on the right side, he's got some mild disease, but on the left side, very significant. As you get close to 0.4, you're talking about tissue loss and gangrene. So 0.4 is really the bottom where you really get concerned about losing the leg, and you want to make sure that you figure out that level of disease so you could plan the appropriate intervention. So just looking at this in a little bit more detail, you can now start to see the numbers, and you can see that there's a big pressure drop from the high thigh to the low thigh, we lose about 60 millimeters of mercury, and anything over 20 millimeters of mercury is considered significant. The other thing we notice here is on the pulse volume recordings, we're losing amplitude as we get to that calf area. And you can see normal amplitude at the thigh, and then we get to the left calf, it starts to decrease. And notice, tardus parvus. It's interesting how the waveforms are consistent through different studies. And you know it's abnormal when you compare it to the contralateral side that has a normal amplitude. So we know from this study that what we're dealing with is a significant lesion at that femoral popliteal level. If I'm going to do a duplex, I can tailor it to the left femoral popliteal level because I know that's where the disease is from this exam. So that's what I'm going to show you. So we start out at the level of the left common femoral artery near the groin, and it looks pretty good. There's maybe a little bit of thickening of the wall, but it's wide open. The velocity is in the normal range. For the common femoral artery, again, close to 60 to 100 centimeters per second. And it's a triphasic waveform. Dr. Pozniak showed you earlier, normal flow in the peripheral artery is triphasic. Forward flow in systole, early dip in diastole because of peripheral resistance, and then the third forward flow component that we see later in diastole because of vascular compliance. Okay? So this is a normal part, but look what happens as we move down into the superficial femoral artery. Then we see elevated velocities, right? We go from 86 to 256. So it's about a threefold increase. Anything greater than 2 to 1 is at least a 50% stenosis. As you get closer to 4 to 1, we're talking about a 75% diameter reduction. And so we have, so what the findings here? Elevated velocities, spectral broadening, and loss of the triphasic waveform. And I'll touch a little bit on this tomorrow as well, as I'll show some other cases. But here's the sign of a significant lesion. And of course, just as I mentioned before, with the renal and mesenteric studies, if I continue downstream, as I head toward the popliteal, classic tardus parvus waveform, confirming that we have a significant lesion, and the velocity went from 256 to 36, showing decreased perfusion of the lower extremity. Okay, so all the classic findings you need for peripheral arterial disease. So here's my last case before we get on to the SAM questions, because I want to get you out on time. 62-year-old male, right upper extremity pain and swelling, history of right arm DVT with a pacemaker placed 11 years ago. Okay, so when you do your upper extremity, we do a lot of venous studies, as you might imagine, and a fair number of upper extremity studies. But there's a big difference between flow in the lower extremity and the upper extremity, right? When you think about lower extremity femoral flow, it's relatively phasic in one direction, right? Like waves on an ocean, right? You see changes in velocity over time. That's the phasicity. But when you do an upper extremity venous study, because you're closer to the heart and there's regurgitation from the right atrium, it's way more pulsatile, and sometimes, frankly, biphasic. So you look for the increased phasicity or pulsatility in the waveforms from the upper extremity, which is what we see here. Now, where the case gets interesting is, as we go from the internal jugular to the subclavian, there's a big change. Now, if you look at that waveform, yeah, I guess you could say it's somewhat phasic because the flow sort of stops and then starts again, but it doesn't have any of the pulsatility in the internal jugular. And this is the same side. Right internal jugular, right subclavian. Now, the color image looks pretty good. It fills in the subclavian vein. So we don't see anything there. So we continue looking down the arm, and here's the subclavian vein medial. So we're coming actually a little bit closer to the neck, and it remains flat. All right? So you say, what's going on? Now, I've always told my sonographers, always check the other side. It's good practice always to compare the contralateral side. And here's the left subclavian. The left subclavian has a nice pulsatile signal, a little bit, you can see a little bit above the baseline, but marked change in velocity over time, which is what you would expect from normal flow into the subclavian. So the left side looks good, but the right side is the problem. And we see that although we have good flow in the internal jugular, we have abnormal flow in the subclavian on the right, and the left side is okay. So the question for you, last case, where is the lesion? Is it in the right subclavian, right innominate, SVC, or axillary vein? Okay, so now we sort of have this race going. Come on, a couple more votes, because neck and neck. All right, so now the innominate is pulling ahead. Now think about the innominate. This is very similar to the case with what I showed you before with the carotid. If it involves the innominate, wouldn't that affect the internal jugular? And I showed you the internal jugular on that side is fine. So it's not going to be the innominate. So, and it's not going to be the SVC because the contralateral side was fine. And it can't be the axillary because that's distal to all of this. That's not going to affect the flow coming back toward the heart if it's further down, if there's an obstruction centrally. So the only choice that makes any sense is the subclavian vein. But I showed you views of the subclavian, I didn't see the lesion. I looked lateral to the subclavian, I looked medial in the subclavian, I didn't see a clot, and I didn't see compression or a mass. So what do you do next? And you don't have to poll on this one. Just think about it. What would be the next test to try to figure out what the heck is going on with the obstruction to flow in that right arm? You could do CT, you could do MR, I don't know, you could do something more invasive, or you don't know. I mean, I did everything I could in the vascular lab. So we opted for CT, and here is a look at what's going on. Patient had a history of pacemaker, and you can see there's a very, very tight stenosis at the most medial aspect of the subclavian as it's emptying into the innominate. And if you look at the axial view, it's practically a pinhole. And you can see very little contrast getting in, and it's markedly narrowed. So this is extreme narrowing of the most medial portion of the subclavian. And although we're not going to see that, the most important point of this case is to recognize that abnormal flow pattern, and that even if you don't see the level of obstruction, you know it's there, and to pursue it.